Have you ever wondered why a patient who looks stable on the ground can suddenly become critically ill just a few thousand feet in the air? The answer surprises many nurses, and it is one of the reasons candidates struggle on the CFRN exam. A single misunderstanding about altitude, pressure changes, or flight physiology can lead to the wrong answer on the test, and, more importantly, the wrong decision during a real transport mission. Before you continue your journey toward becoming a certified flight-registered nurse, there are a few essential concepts you absolutely cannot afford to miss. If you want extra practice, be sure to download the free CFRN study guide linked in the description. It includes some of the highest yield review questions to help reinforce what you learned throughout this video. Welcome to the first section of your CFRN exam preparation course. In this lesson, we are building the foundation that every successful flight nurse needs. You will discover how the flight environment changes the human body, why altitude affects oxygen delivery, how pressure changes influence medical conditions, and how these same forces can impact the equipment you rely on to keep patients alive. Unlike a hospital, an aircraft is a constantly changing environment where physics and medicine work together every second of the flight. Understanding these principles will help you answer challenging certification exam questions with confidence while preparing you for the unique realities of aeromedical transport. By the end of this section, you will have a much clearer understanding of gas laws, altitude physiology, transport logistics, and the critical thinking skills that separate an average test taker from a confident CFRN candidate. Let's get started and begin building the knowledge that will help you succeed on exam day and beyond. One of the most frequently tested concepts on the CFRN exam is Boyle's law, which states that the volume of a gas is inversely proportional to the pressure surrounding it. This means that as your aircraft climbs and atmospheric pressure drops, any trapped gas inside your patient or your medical equipment will expand. For example, if your patient has an untreated pneumothorax, the air trapped in their chest cavity will expand as you gain altitude, potentially causing a life-threatening tension pneumothorax. You must also carefully monitor equipment like air-filled splints, endotracheal tube cuffs, and intravenous drip bags, because the expanding air can increase pressure or alter fluid infusion rates. Always remember to check these air-filled spaces and release pressure as you ascend to keep your patient safe from harm. Dalton's law is another crucial concept, focusing on the partial pressure of gases in any given mixture. This law tells us that the total pressure of an air mixture is the sum of the individual pressures of each gas it contains, such as oxygen and nitrogen. As you ascend in altitude, the total atmospheric pressure decreases, which means the partial pressure of oxygen also drops, even though the actual percentage of oxygen in the air remains exactly the same. This drop in partial pressure is what causes altitude-induced hypoxia in your patients, because there is less atmospheric pressure pushing the oxygen molecules across the alveolar membrane into the bloodstream. To counteract this physical limitation on a flight, you will often need to increase the percentage of supplemental oxygen you provide to your patient as you climb higher into the atmosphere. Moving on to Charles's law, this principle explains the direct relationship between the temperature and the volume of a gas. It states that as the temperature of a gas decreases, its volume will also decrease, provided the pressure remains completely constant. In the flight environment, outside temperatures typically drop as you reach higher altitudes, which can cause gases to contract. While this law is less dramatic in a perfectly pressurized cabin, it is highly relevant during winter helicopter transports or when dealing with pressurized oxygen cylinders. An oxygen tank that reads full on a hot tarmac might show a lower pressure reading once you are flying at a cold altitude, simply because the gas inside the cylinder has physically contracted. Henry's law is the reason why decompression sickness occurs, and it is a very popular topic on the certification exam. This law dictates that the amount of gas dissolved in a liquid is proportional to the pressure of that gas above the liquid. Think of a carbonated soda bottle, where opening the cap releases the pressure, causing the carbon dioxide dissolved in the liquid to suddenly bubble out. Similarly, if a flight crew experiences rapid decompression, or if a scuba diver ascends too quickly, the sudden drop in atmospheric pressure causes the nitrogen dissolved in their blood to form painful and dangerous bubbles. This is exactly why you must carefully assess patients who have recently been scuba diving before they're ever cleared for aeromedical transport. Graham's law deals with how gases naturally move, specifically focusing on the diffusion rate of a gas through a liquid or a biological membrane. It explains that a lighter gas will diffuse much faster than a heavier, denser gas. In the context of flight physiology, This law helps us clearly understand gas exchange in the human lungs at the cellular level. While it is more of a background scientific principle, the exam might test your understanding of how oxygen and carbon dioxide cross the alveolar capillary membrane during transport. Knowing that these gases diffuse at different rates helps explain why certain respiratory conditions worsen so quickly when combined with the physiological stress of altitude. Gay-Lussac's law connects the pressure and temperature of a gas when its volume is kept completely constant. It states that if you heat a gas in a closed, rigid container, the pressure will increase, and if you cool it down, the pressure will decrease. A practical example for a flight nurse is an oxygen cylinder sitting in a hot ambulance or helicopter during the peak of summer heat. The high temperature causes the pressure inside that rigid metal tank to rise significantly, which can become a serious safety hazard if it exceeds the tank's structural limits. Always store your compressed gases properly and be acutely aware of how extreme weather conditions can unexpectedly affect your equipment pressure readings. Beyond the standard gas laws, every flight nurse must deeply understand the 8 recognized stressors of flight, which act together to compromise patient stability. These stressors include decreased partial pressure of oxygen, barometric pressure changes, thermal changes, decreased humidity, noise, vibration, fatigue, and gravitational forces. Each of these environmental factors places an additional metabolic demand on a critically ill patient, meaning their weakened body has to work much harder just to maintain basic life functions. The certification exam frequently asks how to mitigate these specific stressors, so it is your primary job to anticipate them before the flight even begins. By controlling what you can, like wrapping a patient to prevent heat loss or providing necessary hearing protection, you greatly improve their overall chances of a positive clinical outcome. Hypoxia is perhaps the greatest enemy in aeromedical transport, and you must know the 4 specific types, starting with hypoxic hypoxia. This occurs when there is simply not enough oxygen available in the air, or the barometric pressure is too low to force it deep into the lungs. This is the exact type of hypoxia caused by flying at high altitudes without supplemental oxygen or proper cabin pressurization. You will routinely see clinical signs like confusion, cyanosis, and tachycardia as the body struggles to compensate for the lack of oxygen molecules entering the bloodstream. The definitive treatment for hypoxic hypoxia in the flight environment is always to provide high-flow supplemental oxygen or safely descend the aircraft to a lower altitude. The second type is hypemic hypoxia, which happens when the blood has a reduced physical capacity to carry oxygen, even if there is plenty of oxygen entering the lungs. The most common causes of hypemic hypoxia in trauma and transport patients are severe hemorrhage, profound anemia, or carbon monoxide poisoning. In the case of carbon monoxide poisoning, the toxic gas binds to hemoglobin much stronger than oxygen does, essentially locking the life-saving oxygen out of the red blood cells. To fix hypemic hypoxia, you must address the underlying cause, which means physically stopping the bleeding, administering packed red blood cells, or providing hyperbaric oxygen therapy for severe carbon monoxide exposure. Stagnant hypoxia is the third type, and it occurs when the blood flow itself is compromised, preventing oxygen from reaching the body's peripheral tissues. The oxygen is in the lungs, and the blood can carry it, but the heart pump or the vascular pipes are failing to move it around the body. This is classic heart failure, severe shock, or poor circulation caused by high gravitational forces, often referred to as G-forces. When a patient is in cardiogenic shock, their tissues become hypoxic because the sluggish blood flow simply cannot deliver oxygen fast enough to meet their metabolic demands. Treating stagnant hypoxia requires optimizing cardiac output using targeted medications like Vasopressors or Inotropes to get the blood moving effectively again. The final type is histotoxic hypoxia, which is a cellular level problem where the tissues themselves are poisoned and cannot use the oxygen being delivered to them. The airway is perfectly clear, the blood is carrying oxygen, and the heart is pumping well, but the cells are essentially suffocating. The classic exam example for histotoxic hypoxia is severe cyanide poisoning, which completely paralyzes the internal cellular respiration process. Another common cause is severe alcohol or narcotic intoxication, which depresses normal cellular function in the brain and other organs. Treatment heavily relies on administering specific antidotes, like the cyanide antidote kit, to unblock the cellular machinery and allow the tissues to breathe again. The human body goes through 4 distinct stages of hypoxia as altitude increases, and recognizing these stages is vital for your own safety as a flight crew member. The first is the indifferent stage, occurring from sea level to about 10,000 feet, where your night vision might slightly decline, but you generally feel perfectly fine. The second is the compensatory stage, reaching up to 15,000 feet, where your heart rate and breathing actively increase to make up for the lower atmospheric oxygen pressure. The third is the disturbance stage, up to 20,000 feet, where you will clearly experience dizziness, confusion, and slurred speech as your brain becomes starved of necessary oxygen. The final stage is the critical stage, above 20,000 feet, leading to rapid unconsciousness and inevitable death if supplemental oxygen is not immediately supplied. A critical concept related to altitude safety is the time of useful consciousness, which is also widely known as effective performance time. This is the exact amount of time you have to recognize a sudden problem and take corrective action, like putting on an oxygen mask, after experiencing a sudden loss of cabin pressure. At higher altitudes, this available time drops dramatically, sometimes leaving you with only precious seconds to react before you lose the cognitive ability to save yourself. The CFRN exam expects you to know that physical exertion, smoking habits, and general fatigue will significantly reduce your personal time of useful consciousness. This is precisely why all flight crews are strictly trained to secure their own oxygen supply first before ever attempting to help their patients. Gravitational forces, or G-forces, represent another physical stressor that can drastically affect a patient's cardiovascular system during any type of transport. When an aircraft accelerates, decelerates, or turns sharply, the blood in the patient's body pools in different areas depending completely on the direction of the applied force. For example, a sudden acceleration on a runway physically forces blood toward the feet, temporarily decreasing blood flow to the brain and potentially causing a dangerous drop in blood pressure. To actively minimize these effects, critically ill patients are generally loaded so that the forces of forward acceleration push blood toward the brain, rather than away from it. Understanding how to properly position your patient inside the aircraft is a very practical and highly tested transport skill. Vibration and noise are constant, inescapable companions in both helicopter and fixed-wing transport, and they take a heavy physical toll on both the patient and the medical crew. Low-frequency vibrations from the aircraft engines can easily cause muscle fatigue, unnecessarily increase the patient's metabolic rate, and even trigger severe motion sickness or localized pain. Noise not only causes permanent hearing damage over time, but it also completely eliminates your ability to use a traditional medical stethoscope during flight. Because you cannot hear lung breath sounds or take a manual blood pressure, you must rely entirely on visual patient assessments, physical palpation, and your electronic monitoring equipment. Always confidently ensure your patient has proper ear protection and soft padding to dampen the relentless physical vibrations of the aircraft. Thermal changes occur very rapidly in aeromedical transport, as the outside air temperature drops significantly with every single 1,000 feet of elevation gained. Helicopters often have notoriously poor insulation, meaning the internal cabin temperature can fluctuate wildly depending entirely on the weather outside the aircraft. Cold stress forces a patient's body to shiver, which drastically increases their cellular oxygen consumption and burns rapidly through their limited energy reserves. This is especially dangerous for severe trauma patients, small pediatric patients, and burn victims, who already have deeply compromised temperature regulation systems. You must proactively manage their physical environment using warm blankets, heated intravenous fluids, and cabin temperature controls to prevent accidental clinical hypothermia. Before you ever lift off the ground, proper patient preparation and physical packaging are your absolute most important responsibilities as a dedicated flight nurse. Because working space is extremely limited and medical interventions are highly difficult to perform in a moving aircraft, you must anticipate everything the patient might need beforehand. This means securing the endotracheal tube perfectly, placing additional reliable intravenous lines, and ensuring all monitors and infusion pumps are fully charged and functioning correctly. You must also safely secure the patient to the transport stretcher using standardized strap configurations to protect them during unexpected turbulence or hard landings. Thorough medical preparation on the ground always translates directly to a smooth and safe experience in the air. Finally, thoroughly understanding standard interfacility transport protocols ensures a seamless, professional transfer of care between different hospital facilities. As a flight nurse, you are a direct extension of the receiving hospital's critical care unit, and you must maintain or actively elevate the patient's level of care during the entire journey. This involves confidently conducting a thorough pre-flight medical handoff, reviewing the patient's detailed charts, and verifying legal consent for the transport. You must also intimately know your specific program protocols, which legally guide your medical decisions whenever you lose radio communication with your medical director during a flight. Being a true master of your clinical guidelines allows you to act decisively and legally when every single second counts in the air. Congratulations on successfully completing the very first section of your CFRN exam preparation course. I highly encourage you to complete the attached practice test, because answering exam-style questions is the absolute best way to improve your mental retention and measure your true exam readiness. Remember that the practice test is conveniently included with this lesson, and applying what you just learned will permanently solidify these complex gas laws and physiological concepts in your mind. Active learning is your ultimate secret weapon for passing this challenging exam, so take your time with the questions and review any areas where you feel unsure. I look forward to seeing you in the next section, where we will actively tackle the critical topics of safety, survival, and disaster management. Welcome to the second section of your certification journey, focusing entirely on safety, survival, and disaster management. In this vital lesson, you will learn the essential aviation regulations, emergency crash procedures, and triage protocols that keep both you and your patients alive. Understanding these safety rules is incredibly important because the transport environment is inherently dangerous, and you simply cannot help your critical patients if you become a casualty yourself. I want to build your confidence and excitement for this topic, because mastering these specific survival skills will make you a calm, reliable leader during any unexpected crisis. Let us prepare your mind for these critical concepts and dive right into the rules that will keep your flight crew safe. The foundation of aeromedical safety begins with understanding the strict aviation regulations that govern your daily flights. In the United States, commercial air ambulance operations are heavily regulated by the Federal Aviation Administration, primarily under Part 135 rules. These specific regulations strictly dictate crucial safety factors like maximum pilot duty times, mandatory crew rest periods, and the minimum weather conditions required to fly safely. You must remember for your certification exam that the pilot in command always has the final, unquestionable authority over whether a flight is safe to accept. As a flight nurse, you must trust and respect the pilot's final weather decision, even when a critically ill patient desperately needs rapid transport. Crew resource management is a heavily tested concept that originated in the commercial aviation industry to prevent human errors during flight. This vital safety system is designed to completely eliminate steep authority gradients, meaning that every single person on the aircraft has an equal voice regarding safety. In the past, co-pilots or medical crew members were often too intimidated to speak up when they saw a senior pilot making a dangerous mistake. Today, crew resource management actively encourages open, direct communication and requires everyone to speak up immediately if they notice something wrong. This collaborative approach ensures that the entire team works together seamlessly to identify hazards and prevent tragic aviation accidents. A critical component of daily flight safety is the strict enforcement of the sterile cockpit rule. This important regulation states that absolutely no non-essential conversation or distracting activities can occur during the critical phases of flight. These critical phases typically include taxiing, takeoff, landing, and any flight operations occurring below 10,000 feet in elevation. During these high-risk times, you must stop talking about your weekend plans or charting patient notes, and focus your entire attention on looking outside for other aircraft or dangerous obstacles. Maintaining a sterile cockpit ensures the pilot is never distracted during the most complicated and dangerous moments of the transport. When communicating a serious safety concern in a noisy, fast-paced environment, you should use a structured communication tool like the PACE methodology. This simple acronym stands for Probe, Alert, Challenge, and Emergency, and it gives you a clear pathway to escalate your concerns appropriately. You might start by gently probing the pilot with a question about the worsening weather, and if they do not respond appropriately, you escalate to clearly alerting them to the danger. If the dangerous situation continues, you directly challenge the decision, and finally, you declare a clear emergency and demand that the aircraft land immediately. The certification exam wants to see that you understand how to respectfully but firmly escalate your communication to prevent an accident. Weather is the leading cause of fatal helicopter emergency medical service accidents, which brings us to the dangerous practice known as helicopter shopping. This deadly scenario happens when a hospital calls a flight program to transport a patient, but the flight program declines the flight because of terrible weather conditions. The desperate hospital then simply calls a different flight program, hoping they will accept the dangerous flight without realizing the first program already turned it down for safety reasons. To prevent this, dispatchers now actively share weather turned down information across regional networks, so other crews know exactly why a flight was originally rejected. You must always rely on objective weather data and never allow patient condition to cloud your judgment regarding flight safety. Working around active helicopters requires strict discipline, and you must know exactly how to approach an aircraft when the main rotor blades are spinning. You should always approach the helicopter from the front or the side, ensuring you remain in the pilot's direct line of sight at all times. You must never approach from the rear of the aircraft, because the spinning tail rotor is incredibly dangerous and often invisible when it is moving at full speed. Additionally, always carry your medical equipment horizontally and low to the ground, rather than vertically over your shoulder, to prevent anything from striking the main rotor blades. These simple physical rules are absolutely mandatory for protecting yourself, your patient, and the expensive aircraft. Despite all of our safety regulations, emergencies can still happen, and you must know the exact procedures for a pre-crash emergency sequence. If the pilot announces that the aircraft is going down, your immediate priority is to physically prepare yourself for a hard impact. You must quickly secure all loose medical equipment, ensure your seatbelt and shoulder harness are pulled completely tight, and verify that your flight helmet is fastened securely with the visor pulled down. You then assume the standard brace position by sitting upright, crossing your arms firmly over your chest, and tucking your chin down tightly to protect your airway and neck. Staying calm and performing these specific physical actions will significantly increase your chances of surviving the initial mechanical impact. Once the aircraft has crashed and completely stopped moving, your priority instantly shifts to post-crash survival and emergency egress. The most important rule of egress is to wait until all violent motion has completely stopped before you ever attempt to unbuckle your seatbelt. Once everything is still, you must quickly exit the aircraft and immediately move away to a safe distance, usually meeting your crew at the pre-designated 12 o'clock position directly in front of the aircraft nose. You must then quickly account for every single crew member and determine if anyone is seriously injured or trapped inside the wreckage. Never try to be a hero and re-enter a burning aircraft, because your primary duty is to ensure your own immediate survival. After a crash, you must survive until rescue teams arrive, which requires a firm understanding of the physiological rule of threes. This basic survival concept states that a human can survive roughly 3 minutes without oxygen, 3 hours without adequate shelter in extreme weather, 3 days without water, and 3 weeks without food. Because you already have air to breathe, your very first priority after securing the immediate scene and providing basic first aid is finding or building adequate shelter from the harsh elements. Many crash survivors survive the initial mechanical impact only to die hours later from severe hypothermia, which makes finding warmth and shelter your most urgent post-crash responsibility. To ensure rescue teams can find you, every single aircraft is equipped with an emergency locator transmitter, commonly referred to as an ELT. This small radio device is designed to automatically activate upon the heavy physical impact of a crash, sending a continuous distress signal to search and rescue satellites. However, if the device does not activate automatically, you must know exactly where it is located on your specific aircraft so you can activate it manually. One of the most important rules for survival is to stay with the crashed aircraft unless it is completely necessary to move, because a large broken helicopter is much easier for search planes to spot than a single person walking through the woods. Setting up a safe landing zone is another highly tested concept, especially when you are responding directly to an accident scene with local fire and police departments. A standard night landing zone requires a firm, flat, completely clear area that measures exactly 100 by 100 feet. You must actively ensure this specific area is completely free of dangerous overhead wires, loose debris, tall trees, and light poles that could easily strike the fragile rotor blades. The landing zone should be clearly marked with heavy, secure lights at the 4 corners, and local first responders must maintain constant radio communication with the incoming pilot to guide him down safely. When arriving at any chaotic accident scene, your physical approach dictates your overall safety, especially if hazardous materials might be involved. The golden rule for approaching an unknown scene is to always park your vehicle and approach the area from an uphill and upwind direction. This simple physical positioning naturally protects you from toxic heavier than air chemical vapors flowing down the street, as well as dangerous smoke blowing across the accident site. If you ever suspect that hazardous chemicals are present, you must immediately reference your emergency response guidebook to properly identify the substance from a safe distance before you even think about treating the patients. Moving into disaster management, you will frequently encounter mass casualty incidents, which require a complete shift in your standard medical thinking. A mass casualty incident is officially declared any time the sheer number of injured patients completely overwhelms your available medical resources and personnel. During normal daily operations, you spend maximum time and resources trying to save one single critical patient, no matter what it takes. However, during a mass casualty incident, your ethical and medical goal completely reverses, and you must rapidly focus on doing the greatest amount of good for the greatest number of people. To accomplish this difficult shift in care, we use the simple triage and rapid treatment method, widely known as START triage. This standardized system allows you to rapidly evaluate and sort patients into 4 distinct color-coded categories in under 60 seconds per person. The green category is for the walking wounded who only have minor injuries, while the yellow category is for delayed patients who cannot walk but remain physically stable. The red category represents your immediate priority patients who have life-threatening injuries but can still be saved with rapid medical intervention. Finally, the black category is for expectant patients who are either already dead or have injuries so severe they simply cannot be saved with the limited resources available. To quickly determine who belongs in the critical red category during START triage, you evaluate 3 simple physiological criteria, known as the RPMs. RPM stands for respiration, perfusion, and mental status, and evaluating these takes only a few quick seconds per patient. If a patient is breathing more than 30 times a minute, has a delayed capillary refill of more than 2 seconds, or cannot follow simple mental commands, they are immediately tagged with a red ribbon. You do not stop to provide extensive treatment during this rapid sorting phase, other than opening a blocked airway or applying a quick tourniquet to stop massive bleeding. Triage changes significantly when children are involved, which is why we use the specific jumpstart triage system for any pediatric patients. Children naturally have much faster heart rates and breathing rates than adults, so the strict physiological numbers used in adult triage will not work for them. A major difference in the pediatric system is how you handle a child who is not breathing but still has a detectable pulse. Instead of immediately tagging them with a black ribbon like you would an adult, the jumpstart system requires you to provide 5 quick rescue breaths to see if you can jumpstart their fragile respiratory drive. If they begin breathing again, they are tagged red, and if they do not, they are finally tagged black. Any large disaster or mass casualty incident requires extreme organization, which is provided by the National Incident Management System, specifically the Incident Command System. This standardized organizational structure provides clear chains of command, defined operational roles, and a unified strategy for handling complex, multi-agency emergencies. As a flight crew arriving at a disaster, you will typically report directly to the established staging area or the medical branch director, rather than just landing and rushing randomly into the chaotic scene. Understanding the strict hierarchy of the incident command system ensures that all responding agencies work together efficiently without duplicating their efforts or creating more confusion. Communication breakdowns are the #1 failure point in any major disaster response, and you must know how to communicate clearly across different agencies. During a mass casualty incident, you will be working alongside local police, volunteer firefighters, and federal response teams, all of whom typically use different radio frequencies and internal 10 codes. To prevent deadly misunderstandings, the Incident Command System mandates the strict use of plain English on all emergency radio transmissions, rather than using localized slang or specific numerical radio codes. Speaking clearly and simply ensures that everyone from the local sheriff to the incoming flight nurse completely understands the exact same critical message. Congratulations on successfully completing this vital section on safety, survival, and disaster management. I strongly encourage you to take the attached practice test right now to reinforce the critical survival rules and triage categories we just discussed. Answering these specific practice questions is the absolute most effective way to improve your mental retention and boost your overall exam readiness. Remember that the full practice test is conveniently included directly with this lesson, so please take full advantage of it to check your understanding. Keep up your excellent commitment to active learning, and I eagerly look forward to seeing you in the next section, where we will actively tackle advanced airway and respiratory emergencies. Welcome to the third section of our certification course, where we tackle advanced airway and respiratory emergencies. In this vital lesson, you will learn the critical skills needed to assess and manage complex airways in the incredibly challenging transport environment. Understanding these concepts is absolutely essential because a compromised airway is the most immediate threat to your patient's life, and you will not have a backup medical team waiting in the sky to help you. Get ready to build your confidence in advanced ventilation strategies and life-saving surgical interventions that will make you a truly exceptional flight nurse. Let us take a deep breath and dive right into mastering these essential, highly tested techniques. The foundation of excellent airway management begins with a thorough pre-flight assessment using the widely recognized Lemon mnemonic. This incredibly helpful tool stands for Look Externally, Evaluate the 3-3-2 Rule, Mallampati Score, Obstruction, and Neck Mobility. By quickly looking at the patient's physical facial anatomy, measuring their jaw opening, and assessing their neck stiffness, you can accurately predict how difficult it will be to successfully place a breathing tube. Performing this systematic physical assessment on the ground allows you to properly identify a potentially disastrous airway situation before you are trapped inside a small, vibrating aircraft. While the Lemon assessment is fantastic for standard situations, the flight environment requires you to clearly understand the HEAVEN criteria, which is specifically designed for emergency airway predictions. HEAVEN stands for hypoxemia, extremes of size, anatomic challenges, vomit or blood in the airway, exsanguination, and neck mobility issues. This targeted assessment tool helps you anticipate failure when dealing with severe trauma victims or crashing medical patients who are not safely fasting in a quiet hospital bed. Knowing these exact clinical criteria for the certification exam proves you can recognize exactly when standard intubation attempts are highly likely to fail. Rapid sequence intubation is a cornerstone skill for flight nurses, combining a powerful sedative with a fast-acting paralytic medication to secure an airway as quickly as possible. The primary goal of this specific pharmacologic strategy is to rapidly paralyze the patient to prevent vomiting and deadly aspiration during the critical moment of tube placement. You must perfectly time the delivery of your induction agent, like etomidate or ketamine, immediately followed by your paralytic, like succinylcholine or rocuronium. Mastering the exact timing and proper weight-based dosing of these dangerous medications is absolutely essential for taking control of a chaotic airway situation safely. Before you push any paralyzing medications, you must aggressively perform preoxygenation, which is scientifically known as denitrogenation. The goal here is to completely wash out the useless nitrogen gas sitting inside the patient's lungs and replace it with a massive, life-saving reserve of 100% pure oxygen. This built-up oxygen reserve acts as a vital safety buffer, giving you precious extra minutes to place the breathing tube before the patient's oxygen levels drop to a lethal level. If you skip this critical step, especially at higher altitudes, your newly paralyzed patient will become dangerously hypoxic within mere seconds. Even with perfect preparation, intubations can unfortunately fail, which is exactly why you must deeply understand the difficult airway algorithm. This standardized pathway dictates that if you cannot successfully place the endotracheal tube after a maximum of 3 attempts, you must immediately declare a failed airway. At this terrifying moment, you must instantly stop trying to force the tube and shift your entire focus simply to keeping the patient oxygenated. You will rapidly switch to placing a backup rescue device to guarantee oxygen reaches the lungs while you carefully plan your next definitive move. Supraglottic airways, like the King tube or the iGel, are absolute lifesavers when you encounter a failed intubation scenario in the back of a moving helicopter. These simple, clever devices are designed to blindly slide down the throat and perfectly seal off the esophagus, directing all of your pumped oxygen directly into the windpipe. They do not require a heavy laryngoscope or direct visual sight of the vocal cords, making them incredibly fast and easy to insert during extreme aircraft turbulence or poor lighting conditions. The exam expects you to know exactly when to abandon traditional intubation and confidently reach for these vital rescue devices. When all standard tubes and rescue devices completely fail, and you cannot ventilate the patient with a simple bag valve mask, you have entered a cannot intubate, cannot ventilate emergency. This is the most frightening situation in transport medicine, and the only remaining option to save the patient's life is performing a surgical cricothyrotomy. This advanced procedure requires you to quickly use a sharp scalpel to cut directly through the front of the patient's neck, specifically through the cricothyroid membrane, to insert a breathing tube directly into the trachea. You must mentally prepare yourself to execute this aggressive, life-saving surgical cut without any hesitation when absolutely no other options exist. Once the patient's airway is finally secured, your next major responsibility is managing their mechanical ventilation, especially as changing altitude alters the physical dynamics of the lungs. The mechanical ventilator acts as the patient's artificial lungs, precisely pushing a set volume of air and a specific percentage of oxygen with every single mechanical breath. You must carefully program the tidal volume, which is the exact size of the breath, based completely on the patient's ideal body weight, rather than their actual physical weight. Giving a breath that is far too large will severely stretch and permanently damage the fragile lung tissue, causing a deadly complication known as volutrauma. Positive end expiratory pressure, widely known as PEEP, is a critical ventilator setting that holds a small amount of continuous pressure in the lungs at the very end of every exhalation. This gentle, constant pressure prevents the tiny alveolar air sacs from completely collapsing when the patient breathes out, which drastically improves the oxygen transfer into the bloodstream. In the low-pressure flight environment, adjusting the PEEP is one of your best strategies to combat altitude-induced hypoxia without having to rely entirely on maximum oxygen percentages. Understanding how to carefully dial in this specific positive pressure is heavily tested on your certification exam. Troubleshooting a screaming mechanical ventilator in a noisy aircraft is incredibly stressful, so you must absolutely memorize the DOPE mnemonic to quickly identify the specific problem. DOPE stands for displaced tube, obstructed tube, pneumothorax, and equipment failure. If the high-pressure alarm suddenly sounds, you must systematically check if the breathing tube slipped out of place, if a thick mucus plug is blocking the air, or if the patient's lung has popped. Running quickly through this mental checklist ensures you solve the actual mechanical or physiological problem instead of just blindly pushing buttons to silence the annoying alarm. Transporting a patient with a severe asthma exacerbation requires a very specific and delicate mechanical ventilation strategy to prevent deadly internal complications. Asthmatic patients suffer from severe bronchospasm, meaning their lower airways are squeezed extremely tight, making it very hard for them to push trapped air out of their lungs. If the ventilator pushes the next breath in before the previous breath has fully escaped, the trapped air will painfully stack up, continuously increasing the internal pressure until the lung ruptures. To safely prevent this deadly phenomenon, known as auto-PEEP, you must intentionally set the ventilator to provide a very slow breathing rate, giving the patient plenty of time to fully exhale. Acute respiratory distress syndrome, or ARDS, creates a completely different transport challenge, characterized by stiff, fluid-filled lungs that are incredibly difficult to expand. Because the lung tissue is incredibly fragile in this severe disease state, using large breath volumes will easily cause devastating mechanical damage to the alveoli. The gold standard treatment strategy for ARDS patients is known as lung protective ventilation, which requires using very small tidal volumes combined with higher levels of PEEP to gently keep the damaged lungs open. The certification exam will definitely test your ability to recognize this specific inflammatory disease and choose the correct, highly protective ventilator settings. Attention pneumothorax is an absolute, immediate life-threatening emergency that you must recognize and treat aggressively, especially as altitude causes the trapped internal air to rapidly expand. This deadly condition occurs when escaping air builds up immense pressure inside the chest cavity, physically crushing the lungs and completely cutting off blood flow returning to the heart. You will quickly see severe clinical signs like a sudden drop in blood pressure, completely absent breath sounds on one side of the chest, and oxygen levels plummeting dangerously low. The definitive, life-saving treatment you must immediately perform is a rapid needle decompression, pushing a large hollow needle directly through the chest wall to release the trapped, pressurized air. Once a needle decompression relieves the immediate deadly pressure, or if the patient already has a diagnosed collapsed lung, you will often need to manage a surgically placed chest tube during the flight. This thick plastic tube remains continuously inside the chest cavity, actively draining out collected blood and bubbling air to help the collapsed lung re-expand properly. You must constantly ensure that the plastic drainage collection system remains perfectly upright and is placed physically lower than the patient's chest to allow natural gravity to pull the fluids out. Furthermore, You must never forcefully clamp a chest tube during an aeromedical transport, because the changing atmospheric pressures could rapidly cause another fatal tension pneumothorax. Interpreting an arterial blood gas is a mandatory flight skill that clearly tells you exactly how well your patient is physically breathing and chemically balancing their blood. You must accurately look at the pH level to determine if the blood is acidic or alkaline, and then carefully check the carbon dioxide levels to see if the lungs are effectively clearing waste gas. For example, if a patient is not breathing fast enough, toxic carbon dioxide will rapidly build up in their bloodstream, causing a dangerous acidic condition known as respiratory acidosis. You must absolutely know how to adjust your mechanical ventilator settings, like increasing the respiratory rate, to actively fix these specific chemical imbalances during your flight. Continuous waveform capnography is arguably the single most important monitoring tool you possess, providing a breath-by-breath visual measurement of the exact carbon dioxide exiting the patient's lungs. This incredible device provides an instant, graphic waveform on your cardiac monitor that clearly confirms your breathing tube is actually in the windpipe and not accidentally placed in the stomach. During transport, a sudden unexpected drop in the capnography number immediately warns you of a catastrophic problem, such as the tube slipping out or the patient's heart suddenly stopping. You must never transport an intubated patient without having a fully functioning capnography monitor actively recording their exhaled carbon dioxide levels. A common and very tricky trap on the certification exam is confusing the terms hypoxemia and hypoxia, which describe two distinct, yet closely related, physical problems. Hypoxemia strictly refers to a low concentration of oxygen specifically floating inside the blood, which you measure directly with an arterial blood gas or a standard pulse oximeter. Hypoxia, on the other hand, describes the dangerous physiological condition where the actual internal organs and tissues are actively starving for oxygen at the cellular level. You can absolutely have a critical patient who is suffering from severe tissue hypoxia due to poor blood circulation, even if their blood oxygen numbers appear perfectly normal on your monitor screen. Finally, before taking off with a fully intubated patient, you must accurately calculate your required oxygen reserves to ensure you do not run completely out of air halfway through the flight. You must determine the exact flow rate the ventilator requires, multiply that by the estimated duration of the transport, and then add a mandatory safety margin in case of unexpected landing delays. If your mathematical calculation shows your small portable cylinder will run dry before reaching the final destination, you must switch to a larger tank or secure extra cylinders before lifting off the ground. Running out of supplemental oxygen during an aeromedical transport is an absolutely inexcusable error that you must mathematically prevent every single time. Congratulations on successfully completing this incredibly important section on advanced airway and respiratory emergencies. I strongly encourage you to complete the attached practice test right away to immediately reinforce these complex treatment algorithms and advanced ventilation strategies. Practicing with these scenario-based questions is the absolute best way to improve your mental retention and truly measure your overall exam readiness before test day. Please remember that this valuable practice test is conveniently included directly with your lesson, and actively applying your knowledge will build your clinical confidence tremendously. Keep up this fantastic momentum and educational drive, and I look forward to seeing you in the next section, where we will actively tackle severe trauma, burn, and orthopedic management. Welcome to the fourth section of your certification course, where we dive deeply into trauma, burn, and orthopedic management. In this vital lesson, you will learn how to rapidly assess and stabilize the most critical physical injuries you will encounter during transport. Understanding these trauma concepts is incredibly important because life-threatening bleeding and tissue damage require immediate, decisive action to prevent a patient from rapidly deteriorating. Get ready to build your clinical confidence and master the life-saving interventions that make flight nurses so essential in chaotic trauma situations. Let us jump right in and prepare you for the most intense physical challenges on your certification exam. When managing severe trauma in the transport environment, the primary assessment is your absolute most important tool. We historically used the airway, breathing, and circulation method, but modern trauma care now prioritizes stopping massive bleeding before anything else. This shift is represented by the MARCH algorithm, which stands for massive hemorrhage, airway, respiration, circulation, and head injury or hypothermia. The certification exam expects you to know that if a patient has blood forcefully spurting from a severed artery, you must immediately apply a tourniquet before you even think about looking at their airway. If they bleed out completely, securing their airway will not save their life. Shock is a universally tested concept that simply means the patient's internal tissues and vital organs are not receiving enough oxygenated blood. In the trauma environment, the most common type you will see is hypovolemic shock, specifically hemorrhagic shock caused by massive blood loss. When a patient loses too much physical blood volume, their heart naturally beats much faster to try and pump the remaining blood around the body. This is why a sudden, unexplained high heart rate, known as tachycardia, is often the very first clinical sign that your trauma patient is bleeding internally. You must always investigate a rising heart rate in any trauma patient before their blood pressure begins to drop. To actively treat severe hemorrhagic shock during transport, modern flight medicine heavily relies on a strategy known as damage control resuscitation. Instead of pumping the patient full of clear intravenous fluids like normal saline, which aggressively waters down their remaining blood, we now administer actual blood products. You will frequently give packed red blood cells, warm liquid plasma, and clotting platelets to exactly replace what the patient is bleeding out onto the floor. Pumping too much clear fluid actually destroys the fragile blood clots your patient is desperately trying to form, essentially causing them to bleed to death even faster. A critical concept tied to giving these blood products is permissive hypotension, which means intentionally keeping the patient's blood pressure slightly lower than normal. If you aggressively pump fluids to raise the blood pressure to a perfectly normal level, that high pressure will violently blow out the fresh internal blood clots. By keeping the systolic blood pressure just high enough to perfuse the brain and kidneys, usually around 90, you protect those fragile life-saving clots. The exam will definitely test your understanding of why we no longer try to achieve a perfectly normal blood pressure in actively bleeding trauma patients. Tranexamic acid, commonly called TXA, is a life-saving medication you must know perfectly for the exam. This medication does not actually create new blood clots, but it actively stops the body from breaking down the good clots that have already formed. To be truly effective, tranexamic acid must be carefully administered within the first 3 hours after the traumatic injury occurred. If you give it after that strict 3-hour window has closed, the medication can actually increase the overall risk of death for your bleeding patient. Always verify the exact time the accident happened before you prepare this critical infusion. Moving to the head, traumatic brain injuries are incredibly complex and require meticulous transport care to prevent permanent neurological damage. There is the primary brain injury, which is the actual physical damage that occurs the exact moment the skull hits the windshield or the ground. As a flight nurse, you cannot fix the primary injury, but your entire job is to actively prevent the secondary brain injury. Secondary brain injuries happen when the damaged brain cells die hours later because they did not receive enough oxygen or adequate blood pressure during the transport. You must strictly avoid any drops in oxygen levels or blood pressure to keep those injured brain cells alive. When pressure dramatically builds up inside the hard, enclosed skull due to bleeding or brain swelling, it creates a terrifying condition known as increased intracranial pressure. The brain is trapped and begins to physically squeeze down onto the brainstem, which controls basic life functions like your heartbeat and breathing. You must immediately recognize Cushing's triad, which is the classic physical warning sign that the brain is being crushed. This terrifying triad consists of a dropping heart rate, a drastically widening high blood pressure, and a completely irregular breathing pattern. If you see these 3 exact signs, your patient is actively dying and requires immediate, aggressive medical intervention. Spinal cord injuries present another major challenge, particularly because they can rapidly cause a completely different type of cardiovascular collapse called neurogenic shock. When the delicate spinal cord is severed, the brain completely loses its physical connection to the blood vessels in the lower half of the body. Without the brain sending continuous electrical signals to keep the blood vessels tight, they suddenly relax and open wide, causing the blood pressure to plummet instantly. Unlike hemorrhagic shock where the heart beats rapidly to compensate, neurogenic shock traps the heart rate, leaving the patient with a dangerously low blood pressure and a very slow pulse. Chest trauma is responsible for many preventable deaths, and flail chest is a classic exam topic you need to confidently recognize. A flail chest occurs when 2 or more adjacent ribs are physically broken in 2 or more places, creating a floating segment of bone in the chest wall. When the patient breathes in, this broken segment sucks inward instead of expanding out, which is visually called paradoxical movement. While the broken bones are painful, the real deadly threat is the severely bruised lung tissue sitting directly underneath the broken ribs, known as a pulmonary contusion, which physically prevents oxygen from entering the blood. Another deadly chest emergency is cardiac tamponade, which happens when a penetrating injury, like a stab wound, nicks the heart muscle. The heart is surrounded by a tough, inflexible sac, and when blood begins to rapidly leak into this tight space, it physically crushes the heart. The heart simply cannot expand to fill with new blood, causing the patient's blood pressure to drop dramatically. You must carefully watch for Beck's triad, which includes a low blood pressure, bulging neck veins, and muffled heart sounds when you listen with your stethoscope. The ultimate treatment is rapidly inserting a long needle directly into the chest to physically drain the trapped blood. Abdominal trauma is extremely deceptive because the large abdominal cavity can quietly hide massive amounts of internal bleeding without showing obvious outside injuries. Solid internal organs like the liver and the spleen are highly vascular, meaning they bleed heavily and rapidly when they are torn by blunt force trauma. A classic exam clue for a severely ruptured spleen is called Kerr's sign, which is when the patient complains of deep, aching pain in their left shoulder. This happens because the internal pooling blood irritating the diaphragm shares the exact same nerve pathway as the left shoulder, sending a confusing pain signal to the brain. Burn management requires specialized fluid math, starting with accurately estimating how much of the body is actually burned using the rule of nines. This standard system mentally divides the adult human body into sections that represent 9% of the total skin surface area. For example, the entire head is 9%. The entire front of the chest and abdomen is 18%, and each full leg is 18%. For much smaller, scattered burns, you can quickly use the Palmer method, where the size of the patient's actual palm and fingers roughly equals 1% of the total body surface area. Once you know the total burned area, you must calculate the exact amount of intravenous fluid the patient desperately needs using the standardized burn consensus formula, previously known as the Parkland formula. You generally multiply 2 milliliters of fluid by the patient's weight in kilograms, and then multiply that number by the total burned percentage. The most critical rule to remember for the exam is that half of this massive fluid volume must be given within the very first 8 hours. Furthermore, that 8-hour clock starts exactly at the moment the fire occurred, absolutely not at the moment you finally arrived at the hospital. When dealing with facial burns, inhalation injuries are your absolute worst nightmare, because the delicate tissues inside the throat will quickly blister and swell completely shut. You must actively look for obvious danger signs like singed nasal hairs, dark soot completely covering the face, or a hoarse, raspy voice when the patient tries to speak. If you see these signs, you must aggressively secure their airway by placing a breathing tube immediately, long before they actually stop breathing. If you foolishly wait until they are struggling for air, the throat will be so swollen that placing a breathing tube will become physically impossible. Electrical burns are highly deceptive because the tiny, harmless-looking entry and exit wounds on the skin hide massive, catastrophic damage deep underneath. When high-voltage electricity violently shoots through the human body, it cooks the internal muscles and nerves, and frequently disrupts the heart's delicate electrical pacing system. These patients are at extreme risk for sudden, deadly cardiac arrhythmias during your transport, so they require continuous and vigilant cardiac monitoring. Additionally, the massive amount of dead internal muscle releases toxic proteins into the blood, meaning these specific patients require much more intravenous fluid to continually flush their kidneys. Crush injuries happen when a patient's limb is trapped under a heavy object, like a collapsed building or a crushed vehicle, for a prolonged period of time. The heavy weight completely stops blood flow to the limb, causing the muscle tissue to rapidly die and break down. When the heavy object is finally lifted, all the toxic dead muscle proteins and lethal amounts of potassium instantly rush back into the main bloodstream. This sudden rush of toxic potassium can cause the patient's heart to instantly stop beating, which is why you must aggressively administer intravenous fluids and specific medications before the heavy object is ever moved. This severe muscle swelling can also lead to compartment syndrome, a terrifying emergency where the pressure inside a crushed arm or leg becomes dangerously high. The muscles are wrapped in a tough, inflexible web of tissue called fascia, and as the crushed muscle fiercely swells, it chokes off its own blood supply. The patient will complain of extreme, agonizing pain that feels completely out of proportion to the visible injury, and the limb will feel incredibly tight and swollen. The only way to save the dying limb is for a surgeon to physically slice open the tight fascia with a scalpel to instantly relieve the trapped pressure. Orthopedic trauma often involves massive long bone fractures, like a broken femur in the thigh, which can quickly hide several liters of lost blood directly inside the leg. To properly stabilize a mid-shaft femur fracture and reduce the agonizing pain, you will frequently apply a mechanical traction splint that physically pulls the leg straight. However, a major certification exam trap is knowing exactly when you must never use a traction splint. If the patient also has a broken pelvis, applying heavy mechanical traction to the leg will actively rip the shattered pelvis further apart, causing immediate, catastrophic internal bleeding. Congratulations on successfully completing this intense section on trauma, burn, and orthopedic management. I highly encourage you to immediately complete the attached practice test, as it is expertly designed to challenge your understanding of these specific trauma algorithms and fluid calculations. Engaging with these practice questions will solidify your critical thinking skills, improve your long-term memory, and directly enhance your overall exam readiness. Remember that the full practice test is conveniently included directly with this lesson, giving you the perfect opportunity to practice active learning right now. Be proud of the hard work you are putting in today, and I look forward to seeing you in the next section where we cover cardiovascular, neurological, and medical emergencies. Welcome to the fifth section of your certification course, focusing entirely on cardiovascular, neurological, and medical emergencies. In this lesson, you will learn how to expertly manage patients suffering from complex internal failures, ranging from massive strokes to severe toxicological overdoses. Understanding these medical conditions is incredibly important because these patients often require delicate, continuous medication adjustments and advanced monitoring to survive the stress of transport. I am very excited to guide you through these fascinating topics, as mastering these disease processes will truly elevate your critical thinking skills. Let us focus your mind and prepare to dive directly into the intricate world of advanced medical transport. To understand cardiovascular emergencies, you must first master the three basic pillars of hemodynamics, which are preload, afterload, and contractility. Preload is simply the amount of physical stretch in the heart muscle right before it pumps, which is directly caused by the volume of blood filling the heart chambers. Afterload is the amount of physical resistance the heart must forcefully push against to squeeze the blood out into the body's blood vessels. Contractility is the actual physical squeezing strength of the heart muscle itself, regardless of the blood volume or the resistance it faces. Every single cardiovascular medication you give during transport is designed to specifically manipulate one or more of these three vital functions. When a patient's cardiovascular system fails, you will continuously rely on highly potent intravenous medications known as vasoactive infusions to keep them alive. Vasopressors, like norepinephrine, are powerful medications that tightly squeeze the patient's blood vessels, which actively increases the afterload and drastically raises a dangerously low blood pressure. Inotropes, such as dobutamine, are completely different medications that act directly on the heart muscle, forcing it to squeeze much harder and increasing overall contractility. You must carefully monitor these dangerous continuous infusions using a smart pump, because giving too much medication can rapidly cause the heart to work too hard and fail completely. A terrifying cardiovascular emergency you must recognize is an acute aortic dissection, which happens when the inner lining of the body's largest artery suddenly tears. High-pressure blood rapidly shoots into this new tear, ripping the layers of the artery apart and causing the patient agonizing pain that feels like a knife stabbing perfectly between their shoulder blades. A classic exam finding for this condition is a significant difference in blood pressure readings when you check the right arm compared to the left arm. Your primary goal during transport is to keep the patient calm and actively lower their blood pressure and heart rate to prevent the fragile artery from completely bursting. For patients experiencing severe heart failure, you will frequently transport them with a life-saving mechanical device called an intra-aortic balloon pump. This device uses a long, thin balloon placed directly inside the main aorta, which perfectly inflates and deflates in rhythm with the patient's natural heartbeat. The balloon strategically inflates when the heart rests, gently pushing vital blood into the coronary arteries to feed the starving heart muscle. It then rapidly deflates a split second before the heart pumps, creating a sudden vacuum effect that drastically reduces the afterload and makes it much easier for the weakened heart to push blood forward. Transporting a patient with a balloon pump requires a firm understanding of altitude physiology, specifically because the balloon is actively filled with helium gas. Because of Boyle's law, the helium inside that long balloon will naturally want to expand as your aircraft climbs into the thinner atmosphere. If the machine does not adjust for this physical change, the expanding balloon could easily rupture the patient's aorta or violently tear the fragile internal balloon material. You must absolutely ensure that the balloon pump machine is set to automatically purge and refill its internal gas lines as you ascend and descend during the flight. Shifting to neurological emergencies, you must quickly differentiate between the two major types of strokes, because their treatments are completely opposite. An ischemic stroke occurs when a traveling blood clot perfectly blocks a blood vessel inside the brain, completely starving the surrounding brain tissue of vital oxygen. A hemorrhagic stroke happens when a weakened blood vessel completely bursts open, causing high-pressure blood to rapidly flood directly into the delicate brain tissue. Because these two strokes look identical from the outside, you absolutely cannot give any dangerous clot-busting medications until a brain scan proves there is no active bleeding inside the skull. If a patient is diagnosed with an ischemic stroke, time is your absolute most precious resource, because millions of brain cells die every single minute the blood flow is blocked. If the patient arrives within a strict time window, usually under 4.5 hours from the moment their symptoms started, they can receive powerful clot-busting medications. During transport, you must keep their blood pressure slightly elevated to help physically push oxygenated blood past the blocking clot to reach the starving brain cells. However, you must meticulously monitor this pressure, because pushing the blood pressure too high can easily cause the damaged tissue to suddenly start bleeding. A hemorrhagic stroke requires a completely different management strategy, heavily focused on aggressively lowering the patient's blood pressure to stop the internal bleeding. As blood pools inside the skull, it drastically increases the intracranial pressure, which violently crushes the healthy brain tissue against the hard bone. To combat this deadly pressure during flight, you must keep the patient's head perfectly elevated at a 30-degree angle to help venous blood drain out of the skull. You must also proactively treat any severe pain or sudden nausea, because vomiting or intense physical pain will immediately cause the brain pressure to spike dangerously high. Status epilepticus is a terrifying neurological emergency where a patient suffers from continuous, unrelenting seizures that do not naturally stop. During a major seizure, the human brain burns through massive amounts of oxygen and vital glucose, quickly leading to severe tissue damage and dangerously high body temperatures. The immediate priority is always securing the patient's flailing airway, followed quickly by administering fast-acting sedative medications like midazolam to forcefully stop the chaotic electrical activity in the brain. You must also check a blood sugar level immediately, because severe hypoglycemia is a very common and easily reversible cause of transport seizures. Autonomic dysreflexia is a very unique and highly tested emergency that strictly occurs in patients who have older, existing spinal cord injuries located high up on their back. It is a massive, completely uncontrolled spike in blood pressure triggered by a simple irritation below the level of their old injury, like a full bladder or a tight seatbelt. Because the spinal cord is permanently broken, the brain cannot send the necessary calming signals down the body to turn off this massive chemical adrenaline dump. If you see a paralyzed patient suddenly develop a pounding headache and a dangerously high blood pressure, you must immediately search for and remove the hidden physical irritation. Moving into complex medical conditions, diabetic ketoacidosis is a severe emergency primarily affecting type 1 diabetics who completely lack internal insulin. Without insulin acting as a key to let sugar into the cells, the starving body desperately begins burning fat for energy, which creates highly toxic acids known as ketones. The patient will breathe very rapidly and deeply, known as Kussmaul respirations, in a desperate physical attempt to blow off the toxic acid as carbon dioxide gas. Your primary transport treatment involves aggressively pumping large amounts of normal saline to fix their severe dehydration, followed by a very careful, continuous infusion of regular insulin. A closely related diabetic emergency is the hyperosmolar hypoglycemic state, which typically affects older patients suffering from type 2 diabetes. These patients still produce a tiny amount of insulin, which is just enough to prevent the body from burning fat and creating toxic ketones. However, their blood sugar levels rise astronomically high, creating blood as thick as syrup, which forces the kidneys to urinate out massive amounts of body fluid. These specific patients suffer from a much deeper, more dangerous level of physical dehydration than ketoacidosis patients, meaning your absolute main priority is massive, aggressive intravenous fluid replacement during the flight. Toxicological emergencies are common in transport, and you must know the specific antidotes for common dangerous medications, starting with acetaminophen. While this common pain reliever seems completely harmless, a massive overdose quietly and permanently destroys the liver over a period of several days. The patient might actually feel perfectly fine during your transport, but their internal organs are actively dying if they do not receive the specific antidote called N-acetylcysteine. The certification exam expects you to know that the exact time the patient swallowed the pills is the most critical piece of information needed to determine if the antidote will actually work. Organophosphate poisoning is a deadly toxicological emergency caused by exposure to strong agricultural pesticides or dangerous military nerve agents. These toxic chemicals overstimulate the nervous system, causing the body's fluid gates to completely open, leading to the classic sludge syndrome. You will see uncontrollable salivation, lacrimation or crying, urination, defecation, severe stomach cramps, and active vomiting. To save the patient from drowning in their own massive lung secretions, you must rapidly push enormous, continuous doses of a medication called atropine until their skin turns completely dry. Sepsis is a massive, system-wide medical emergency where the body's own immune system severely overreacts to a simple local infection. This violent immune response forcefully dilates all the blood vessels in the body at exactly the same time, causing the blood pressure to absolutely plummet. The tiny capillaries also become incredibly leaky, allowing vital fluid to dangerously seep out of the blood vessels and swell into the surrounding tissues. The absolute best way to treat severe sepsis is to immediately administer broad-spectrum antibiotics and rapidly push large, heavy volumes of intravenous fluids to physically fill up the widely dilated pipes. Transporting a patient in severe septic shock requires extreme vigilance, because aggressive fluid therapy alone is often not enough to keep them alive. If you have rapidly pumped several liters of fluid and their blood pressure is still dangerously low, you must quickly start a powerful continuous vasopressor infusion. You must also draw blood to check their internal lactic acid levels, because a high lactate number clearly proves that their deep tissues are actively starving for oxygen. Recognizing these subtle signs of worsening shock allows you to aggressively intervene before the patient's internal organs permanently shut down. Interpreting complex acid-base balances is incredibly important when dealing with these severe medical and toxicological emergencies. When a patient suffers from deep shock, sepsis, or diabetic ketoacidosis, their blood fills with toxic metabolic waste, creating a dangerous state called metabolic acidosis. The human body naturally tries to fix this acid problem by forcing the lungs to breathe much faster, blowing off acidic carbon dioxide gas to chemically balance the blood. If you mistakenly give a powerful sedative to a patient who is breathing fast to survive, you will stop their breathing and they will rapidly die from the overwhelming internal acid buildup. Finally, severe electrolyte imbalances, particularly high potassium known as hypokalemia, can cause immediate and catastrophic cardiac arrest during flight. This dangerous condition frequently occurs in patients suffering from complete kidney failure or massive muscle crush injuries. The absolute first warning sign of deadly high potassium is seeing tall, sharp, peak T waves clearly displayed on your cardiac monitor. To save the patient's heart from instantly stopping, you must rapidly push intravenous calcium to physically shield the heart muscle, followed quickly by insulin and sugar to forcefully hide the extra potassium back inside the cells. Congratulations on successfully completing this very dense and challenging section on cardiovascular, neurological, and medical emergencies. I strongly encourage you to take the attached practice test right now, as these medical concepts are highly complex and require repeated exposure to fully master. Remember that the practice test is perfectly integrated with this lesson, and answering these specific scenarios will absolutely guarantee your retention of these critical disease pathways. Keep pushing forward with your active learning, because your dedication is clearly preparing you for certification success. I will see you in our final lesson, where we will confidently master the unique challenges of special populations and obstetric emergencies. Welcome to the final section of your certification course, where we focus on special populations and obstetric emergencies. In this lesson, you will learn the incredibly delicate nuances of treating pediatric, neonatal, and pregnant patients during transport. Understanding these specific groups is critical because the unique anatomical and physiological differences completely change how you must approach their medical care. Get ready to build your confidence in managing these high-stress situations and master the final skills needed to become a truly exceptional flight nurse. Let us finish this course strong and dive into the vital concepts that protect our most vulnerable patients. The most important difference in pediatric patients is the unique airway anatomy, which makes intubation significantly more challenging. Children have proportionally much larger heads, shorter necks, and very large tongues that easily fall back to block their airway. Their epiglottis, the tiny flap that covers the windpipe, is long and floppy, requiring a specialized straight blade to safely lift it out of the way during intubation. Additionally, the narrowest part of a small child's airway is the cricoid ring located below the vocal cords, which acts as a natural seal for breathing tubes. When evaluating pediatric breathing, you must understand that small children rely almost entirely on their diaphragm muscle to pull air into their lungs. Because their chest muscles are underdeveloped, any respiratory distress will immediately cause visible pulling around their ribs, which we call physical retractions. You will also notice nasal flaring and a distinct grunting sound when they exhale, which is their natural physical attempt to keep their tiny airways open. Because children have an extremely high metabolic rate, they burn through their oxygen reserves very quickly, meaning they will desaturate and turn blue much faster than an adult. Pediatric circulation and shock management completely revolve around their heart rate. Unlike adults who can squeeze their heart muscle harder to increase blood flow, a child's heart-stroke volume is completely fixed, meaning they can only increase their heart rate to survive shock. This makes unexplained tachycardia, or a very fast heart rate, the absolute earliest and most critical warning sign that a child is bleeding or severely dehydrated. A child will maintain a perfectly normal blood pressure for a very long time, and when their blood pressure finally drops, they are actively crashing and minutes away from cardiac arrest. When a pediatric patient does go into shock, your fluid resuscitation math must be incredibly precise to avoid accidentally flooding their small bodies. The absolute standard for a pediatric fluid bolus is 20 milliliters of fluid for every single kilogram of the child's body weight. Because estimating a child's weight during a chaotic emergency is highly prone to human error, you must heavily rely on a color-coded length-based measurement tool, commonly known as a Broslow tape. By simply measuring the child's physical length, this tape immediately provides their estimated weight and the exact safe dosages for every critical transport medication. Moving to newborns, the Neonatal Resuscitation Program guidelines dictate a very specific, inverted pyramid approach to saving a baby right after birth. Unlike adult cardiac arrest where you immediately start chest compressions, the vast majority of newborns simply need basic respiratory support to survive. Your very first actions should always be physically drying the baby, keeping them warm, and vigorously stimulating them to encourage natural breathing. If the baby does not begin crying and breathing adequately after basic stimulation, you must immediately begin providing gentle breaths using a specialized infant bag valve mask. The most critical vital sign you must evaluate in a newly born infant is their heart rate, which dictates your exact treatment pathway. You should quickly measure the neonatal heart rate by listening closely to the chest with your stethoscope or gently feeling the pulse at the base of the wet umbilical cord. If the heart rate drops below 100 beats per minute, you must immediately begin positive pressure ventilation to force oxygen into their lungs. If the heart rate plummets below 60 beats per minute despite your perfect ventilations, that is the exact moment you must begin performing delicate neonatal chest compressions. Some infants are born with severe congenital heart defects that physically prevent oxygenated blood from properly circulating through their tiny bodies. These specific babies rely entirely on a fetal blood vessel called the ductus arteriosus, which naturally tries to close shortly after birth. If this vital vessel closes, the baby will quickly turn deeply cyanotic and die, making them entirely ductal dependent for their immediate survival. During transport, you must continuously administer a specialized intravenous medication called prostaglandin E1, which chemically forces that fetal blood vessel to stay wide open. While prostaglandin E1 is absolutely life-saving for these cardiac infants, it carries a very dangerous and highly tested side effect that you must anticipate. This powerful medication frequently causes central apnea, meaning it chemically signals the infant's brain to completely stop breathing. Because of this high probability of sudden respiratory arrest, it is a standard transport practice to proactively intubate and chemically paralyze these neonates before you ever load them into the aircraft. You must take complete mechanical control of their airway on the ground to guarantee they do not stop breathing halfway to the pediatric cardiac center. Neonatal thermoregulation is another massive transport challenge, because small infants lose body heat incredibly fast due to their large surface area and lack of insulating fat. Unlike older children, newborns cannot physically shiver to generate warmth, so they rapidly burn through their specialized brown fat stores when exposed to a cold helicopter cabin. This cold stress drastically increases their oxygen consumption and causes their blood sugar to crash, leading to severe hypoglycemia and respiratory failure. You must actively use a specialized heated transport isolate, warm blankets, and chemical warming mattresses to aggressively protect the infant's fragile body temperature. Shifting our focus to pregnant patients, you must clearly understand the massive physiological changes their bodies undergo to support a growing fetus. During pregnancy, a mother's total blood volume naturally increases by roughly 50%, and her resting heart rate significantly speeds up to pump that extra fluid. Because of this massive internal fluid reserve, a pregnant trauma patient can lose over a third of her entire blood volume before she ever shows the classic signs of shock. Unfortunately, her body will aggressively shut off blood flow to the baby to save herself, meaning the fetus can easily die from oxygen starvation long before the mother's blood pressure drops. Supine hypotensive syndrome is a very dangerous physical complication that occurs when you lay a heavily pregnant patient flat on her back during transport. The massive physical weight of the growing uterus forcefully crushes down on the inferior vena cava, which is the main vein returning blood back to her heart. This physical blockage causes her blood pressure to plummet, making her instantly dizzy and severely cutting off vital blood flow to the placenta. To instantly fix this dangerous problem, you must always tilt the pregnant patient slightly to her left side using a wedge or rolled blankets to physically shift the heavy uterus off the vein. When managing a severe trauma involving a pregnant patient, you must remember the absolute golden rule of obstetric transport. The mother is always your primary patient, and the only way to effectively save the unborn baby is to aggressively resuscitate the mother. You must never withhold life-saving oxygen, critical medications, or necessary diagnostic X-rays simply because you are worried about the fetus. If the mother stops breathing or bleeds to death, the baby will certainly perish, so you must treat maternal trauma rapidly and aggressively to protect both lives. Preeclampsia is a severe cardiovascular complication of pregnancy characterized by dangerous high blood pressure, extreme fluid swelling, and protein leaking into the urine. These patients frequently complain of a massive, pounding headache and severe visual changes like seeing bright spots, which means their brain is dangerously swollen. If left untreated, this high-pressure state actively damages the mother's internal organs and severely limits the essential blood flow reaching the growing baby. You must keep the patient incredibly calm during transport, dim the aircraft lights, and minimize all sudden loud noises to prevent triggering a massive seizure. If a patient with preeclampsia suddenly begins seizing, the condition instantly upgrades to eclampsia, which is a true, life-threatening neurological emergency. The definitive transport treatment for these specific seizures is an intravenous infusion of a heavy metal called magnesium sulfate. Unlike standard seizure medications that just slow down the brain, magnesium sulfate acts as a powerful smooth muscle relaxant that aggressively lowers the high blood pressure and calms the hyperactive nervous system. You must strictly monitor this infusion because giving too much of this powerful medication will paralyze the mother's breathing muscles. Because magnesium sulfate is so incredibly powerful, you must actively watch for the dangerous signs of magnesium toxicity during your flight. The very first clinical sign that the magnesium levels are climbing too high is the sudden loss of the patient's deep tendon reflexes, such as the simple knee-jerk reaction. If the toxicity worsens, the patient will suffer severe respiratory depression and their heart rate will drop dangerously low. If you observe these terrifying signs, you must immediately stop the magnesium drip and rapidly push the specific chemical antidote, which is calcium gluconate, to reverse the lethal effects. Postpartum hemorrhage is a massive bleeding emergency that can rapidly occur immediately after the baby and the placenta are successfully delivered. The most common cause is uterine atony, which means the large uterus muscle has become tired and incredibly soft, failing to naturally clamp down on the bleeding blood vessels. To actively stop this life-threatening hemorrhage, you must aggressively perform a fundal massage by deeply kneading the mother's lower abdomen to physically force the muscle to contract. You will also frequently administer a powerful intravenous medication called oxytocin, which chemically forces the uterus to clamp tightly shut. A prolapsed umbilical cord is a rare but catastrophic delivery complication where the vital cord slips out of the birth canal before the baby does. When the heavy baby descends, it physically crushes the exposed cord against the pelvic bone, instantly cutting off all oxygenated blood flow from the placenta. You must immediately instruct the mother to stop pushing, and you must physically insert your gloved hand into the birth canal to actively push the baby's head off the crushed cord. You must hold your hand in this exact position for the entire flight to the hospital, keeping the exposed cord covered with warm, moist dressings. Shoulder dystocia is another terrifying delivery emergency where the baby's head delivers normally, but their wide shoulder becomes physically wedged hard behind the mother's pubic bone. You cannot simply pull on the baby's delicate head, or you will permanently rip the vital nerve bundles in their neck. Instead, you must rapidly perform the Macroberts maneuver, which involves sharply flexing the mother's knees back tightly against her chest to physically open her pelvis wider. You must apply this specific physical positioning while another crew member pushes firmly on the lower abdomen to physically dislodge the stuck shoulder. Congratulations on successfully completing this final section and finishing the entire exam preparation course material. I strongly encourage you to complete the attached practice test right now, because applying these complex obstetric and pediatric concepts is vital for your final review. Remember that practicing with these exam-style questions actively builds your long-term retention and guarantees your readiness for test day. The practice test is included right here with this final lesson, so take full advantage of it to measure everything you have learned. Thank you for your incredible dedication to active learning, and I wish you the absolute best of luck on your certification exam.